Hi everyone, I'm here to talk to you about a game changer. I really mean it, a game changer in implant dentistry like I've never seen in the 25 years that I've been doing implant dentistry. The reason has to do with primary stability. Up until I started using the BLX implant, I really had no control over how an implant was bonding in the bone, osseointegration as it's often called. But now I control it. In this brief video, I'm going to show you how we place the BLX implant, and then later I'll show you how we restore this patient with Novalock abutments to assist her wearing a loose lower partial denture. Read this. It says Strauman BLX confidence beyond immediacy. What that means to me and probably to you is that this system, using this implant, has been designed for immediate placement, and not just immediate placement anywhere, but immediate placement into a extraction site, into a socket. But the reality is it's a lot more than that. This implant has replaced every other scenario that I used an implant for, and I'm happy to show you in this presentation why primary stability with this implant is better than anything else that I've used. Our patient today is Valentina. This is her picture. Now Valentina, she's 96 years young. Although she has senile dementia, some heart problems, takes anticoagulants, she's a vibrant young lady. Her problem has to do with her dentures. Let me show you what happened to her in the earliest part of her treatment and why we're here doing implant surgery today. Half a year ago, Valentina came to me with her daughter and said that she had pain in her mouth, a bad taste, and she couldn't eat her food. Looking at her dentition, we can see many teeth that have rampant decay and periodontal disease. In the lower left side, you can see the entire area is engulfed in infected tissue, whereas some teeth really don't have much decay beyond that point. This upper tooth really doesn't need to be extracted. It can just be leveled off at the gingival crest. I don't want to take out any tooth in her mouth that I don't have to, but where there's rampant infection and or periodontal disease, I have no choice. So in her mouth, I'm going to take out these teeth here. I'm going to leave that one in, and I'm going to take out all of these teeth. When I first met Valentina, she was wearing an upper removable partial denture and a lower removable partial denture. Taking the upper removable and lower partial denture out, you can see that she has these upper anterior teeth with rampant decay, this lower left bridge with rampant decay, and nothing in the right posterior. This is what her occlusal plane looks like, and this is what her soft tissues look like on the right side. Notice already that she's lost a considerable amount of soft tissue, and it's quite inflamed in this area as we see it at first assessment. This is what our lower teeth look like against the edentulous maxilla. Following the removal of all remaining upper teeth and lower left posterior teeth, this is the healing 6 months after tooth extraction. Looking at the right side, you can see that the soft tissues again seem to be going apical, and this will be looked at a little bit more in detail at the surgery appointment. Generalized recession in the mandibular anterior region, and the patient's home care is not nearly as good as it might have been when she was younger. Here is what her left side looks like, and you can see we did keep that one root, and it's causing no problems. So this is the lower removable partial denture that she's wearing. And the problem for her is that even though she has an upper complete denture against a lower removable partial denture, this is a long lever arm. And because it's a long lever arm, she's getting a lot of movement along the fulcrum, which is just the distal of the tooth number 43 and the distal of the tooth number 33. And she says that upper complete denture is not a problem. She is able to wear it, and during the healing period, as her tissues are changing, she just uses polygrip, and it helps her wear the denture with no problem. But there's nothing that she can do to make this lower prosthesis more comfortable, because the lever arm causes it to move. So what I proposed for her was the placement of a dental implant right here, and another dental implant right here with Novalock locators, bringing the length of the lever arm to a shorter length. So now it'll be here, but now we will have the benefit of circumferential clasping and locator in this area and in this area in order to increase the retention of the denture base. She and her daughter have discussed it thoroughly, and even though this lovely lady has some senile dementia, she's very much pleased with the treatment recommendations. The BLX implant reminds me of a wood screw, a screw going directly into wood, and it grabs as it goes down. The thread pitch that you see here is very aggressive as it grabs onto bone. But there's something else that's very interesting. These right here, these grooves, are on both sides. Follow on the implant here. There's one groove there, and then there's another groove there. So the purpose of this is that as the implant gets screwed into place, all the bone that gathers gets pulled along this channel and up towards the top. And since a socket is generally more narrow here and wider here, it deposits new bone at the widest part of the funnel, which is an excellent way of growing bone, if bone is necessary, at the cervical alveolar crest. So here is the maxilla and the mandible after 6 months of healing. You can see that on the right side, the bone is very robust, and there is no signs of healing because there was no recent tooth extractions. We've placed a little jig in the area with some metal pins. We tried to get them parallel, but it's not the parallelism that we want at this stage. We just want to see where the center of the implant will be. So we see it's right here, and now we can follow down and we can see where the mental foramen is located, and we can tell that we can go down at least 12 millimeters in this site without being concerned that we're going to be anywhere close to the mental foramen. Similarly, on the other side, you can see here's the socket of the original tooth that was extracted and the second socket, but you can also see that the mental foramen is located distal, and if we continue to place our implants in these sites, we'll be fine. We're going to give a mandibular block, and we're also going to place some infiltration anesthetic in the 45-44 area as well. We're only going to be using 1 in 200,000 ultracaine because she's on 3 heart medications, and it's not a good idea to be using stronger epinephrine. She takes Eliquis, an anticoagulant, but this drug has been withdrawn 5 days ago. My technique is to inject just a little bit of local anesthetic back in the mandibular fossa area, just to numb the soft tissues there. This is a panoramic radiograph that was taken just a half hour ago, and you can see that we have some metal here and here. We're interested in seeing where the mental foramen is. The metal tends to intensify on the radiograph where the mandibular canal is and where the mental foramen is. So you can see the mental foramen on both sides. We're not too much concerned about the angulation that we see in this metal. We're going to correct that when we get into the mouth. And we're going to use the same guide that we used. We've taken out the metal in the middle, and all we want to do is to drill a hole through the skin and into the bone and make a marker in the bone. Once we've gone ahead and made a marker in the bone, then we'll go ahead and we'll correct our long axis of the drill so that the drill is going parallel with the canine on both sides. On the left side, you can see an extraction was done in this area. There is good bone fill, but not nearly as nice as it is on the right side. We'll see more of this when we flap the soft tissues. This is the needle drill. This is the drill that we're going to use to make a marker through the skin and into the bone. We're going to place this little guide back in the mouth. We're drilling at 600 RPM, and we're going to stay parallel and in the middle. You can see where the marker has been made. And we've made it a little bit deeper. Okay. Our flap is going to stop with a vertical release over here. We're going to extend it across the alveolar crest, back to about here, and then we're going to have a Bombay release on both sides. We want to have a clear visualization of the area. So we'll start with the vertical release. It's going to bleed a little bit more because we're using 1 in 200,000. But the removal of the aliquot will greatly assist us. Okay. Number 15, please. Suction right here. Okay, give me the middle periosteal elevator, please. Okay. I think you all can see something that we didn't expect to find here. There's a defect right here on this side, and it's adjacent to where we're placing the implant. Since we have this area exposed, we're going to do a curettage of this area, and we're going to place some emdogain and some bone in this area at the same time. That way we can help keep this tooth a little bit longer. We're going to plateau the ridge just slightly, and we're spinning in reverse. You're going to feel a little bit of vibrating, but you should feel no pain. Okay. We're just a little bit off. We're going to move just a little bit further into the middle of our area, and we'll stay parallel to the long axis. Suction on bone, please. That's right, you stay right on the bone. So here's our alignment pin. We're going to place it into the surgical site so that we can take a radiograph. And it looks already like it's fairly parallel to our canine. Okay, Rosa, let's get ready for a radiograph. You can take a canine view if you like. Open just a little, open a little, close now. Perfect. Okay, guys. We have just inserted the aligning pin in order to see how far we are into the bone and whether or not we are in the correct position. I'm very happy with the position relative to the adjacent tooth. We're down 12 millimeters, and so all I wish to do in this location is to expand the size so that we can place a 4.0 diameter implant. Our round burr is being used just at the orifice, just so that when we put the 2.8 in, we don't have any shaking. Okay. So now you can see we've lined it up just a little bit towards the distal. Okay, so the decision has to be made if we're going to go with a diameter of 3.5 or 4 millimeters. It looks like we could definitely go with a 4 if we moved in just a little bit. So if we went with a 4 millimeter diameter, using the BLX kit, we would want to go up one, and we would be using a 3.2 millimeter diameter burr. So that's what we're going to do. We're going to go with the white drill, and we're going to take it a little bit more towards the lingual. And we'll then be using a 4.0 diameter. So when I put this in order to get it to go more to the lingual, I'm going to push in as I go down. And there we go. Okay, we're going to stop at 3.2 because we want to be able to ratchet to tighten. That's the difference between BLX and BLT, is that you want to be able to use your ratchet so that you can get primary retention. So this is our BLX implant, and you'll take a look at how it comes out. There are the information that you need to see, the taper, the width, the length. So this is what the implant looks like. Here, there's a very tiny area of metal, titanium, and what we're going to do is we're just going to place this in, and then all we're going to do is bend it. Now it's ready to go ahead and be used in the mouth. We're going to start to drill this into place. It won't go very far before we need to use a ratchet. We found that the bone density was a little harder than we thought, so we've decided to go up one more diameter. So we're going to 3.5. Stay on bone, honey. Okay. We're going to spin at 15 RPM, which is much lower than normal, but you have to keep the drill spinning low when you start. And we're about halfway in, and it's time to ratchet. It won't go any further. So now we're going to use the ratchet from the hand instrument kit. It's in place. We're going to apply our torque, We're going to spin clockwise. Open a bit, sweetie. The amount of primary retention we have now is amazing. We're already up to 50 Newton centimeters of force. So if you can zero in here, we're about 55 Newton centimeters of force to fully seat it. The primary retention here is amazing. Let's take this. And you can see it's down. Okay. Because we're going to put some M-degain and some bone against this tooth root, we're going to want to put a closure screw in here that allows us to seal the tissues and not have any part of a healing abutment sticking above the soft tissues. It's recommended to use your hand to place these closure screws and not to put much force when you seat and tighten these closure screws, because they can easily bind, and sometimes bind before they come to a full seat. Can you see the circular thread that's exposed right there?
Yep, right there. Yep.
We're going to go ahead and we're going to add bone in that area when we add bone here. So I'm not worried. And of course, all around the rest of it is fully embedded in bone. The implant has now been placed on the lower right side. The implant on the lower right side was a 4.0 by 12 millimeter BLX implant. We achieved a primary stability of over 55 Newton centimeters of force in order to place it to its most apical position. In this region here, we dealt with this area by applying bone, by applying some M-degain against the root, and of course we curetted around the root in order to assist us getting bone to reattach in this region. Okay. So it seems like it's off a little bit there. We're going to move it again, but we've got a marker, but we're going to move it closer to the middle of the alveolar ridge. Okay. And I'll take a number 15 blade. Okay. Okay. So on this side, we're going to do the same thing. We're going to put a vertical release right here. We're going to follow it around, come back to about the second premolar, and then we're going to have two Bombay flaps going on both sides. And here we go.
Okay.
You're good where you are?
Yeah.
Just don't go any quicker.
Okay.
Ready with the small paraceal element? Yep. Give me the medium size.
Sure.
There's the hole that's more buccal.
Okay.
There's the alignment drill hole that's a little bit more to the lingual, and we'll go right dead in the middle. Okay? How am I doing? You like my angle?
I do, yeah.
You sure I'm parallel?
Uh-huh.
Okay, okay. Yeah, from this point.
Suction right on bone. Stay on bone, honey. I have to see if I'm down all the way. I think we're okay. Let's go to the next one. Okay. Let's go ahead and switch to the number 4x12. You say 4x12?
4.0, yeah.
Okay. Yeah, that's good. Okay. Okay. That went in a little bit further because this was a previous extraction site, so the bone is a lot softer. But there's still enough that we can ratchet further. Can you see how much is sticking out?
Yeah.
Okay. And you can still see where that we're parallel.
Mm-hmm.
Okay.
I haven't got my level with me, but yeah, I think it was pretty parallel.
Okay. Got that? Bring the mirror or the retractor there. Take the Minnesota retractor. Great. Now, okay, let's take a look at that and see how it is. That's tight. Okay, let's get a radiograph. Close together.
Okay, stay
That's
like
it.
that. Perfect. Just stay.
This is the lower left side. The implant has been placed in this side too. The implant is again a 4.0 by 12 millimeter implant. You can see on the mesial aspect that we're up against solid bone, but on the distal aspect we're up against bone that's healing from the original tooth extraction. I would say that we achieved about 25 Newton centimeters using the ratchet in order to place this. It was a lot better than what you would normally get by just putting a implant in with a drill, spinning it into place, but you would expect that in this site right here, it's going to take longer for the implant to bond to the surrounding bone. My experience with the BLX system has been very positive. I was told initially that it would just be a system for me to use when I was extracting a tooth and I wanted to immediately place a dental implant and possibly even restore the implant if the primary stability was that good. It's been a lot more than that for me, and that's why I called it a game changer at the beginning of this video. Take a look at this radiograph here. The patient is obviously going to lose this bridge and this tooth, but wouldn't it be amazing if we were able to extract the tooth and to be able to place an implant directly into that socket? We can do a junction between a natural tooth and the implant further in treatment, but it has turned out to be surprisingly very easy to place an implant into the site. Take a look at the implant placement on the same day as the surgery. I have to tell you that the primary stability was close to 55 Newton centimeters when I torqued that implant into place. The next thing I want to talk to you about is the comparison of the tissue level implant to the BLX implant. Take a look at this view over here. The tissue level implant has always been known as the gold standard in Strauman implant dentistry. The reason being that the interface between the coronal surface and the implant itself is remote from the alveolar crest, where the roughened surface of the implant meets the alveolar crest. If you take a look at a radiograph for a patient who has a TLX implant, even in the aesthetic zone, you can see that by placing the finish line of the crown remote from the roughened surface, it promotes good bone to roughened surface at the alveolar crest. Further, let's compare the gold standard to the BLX implant. As you can see here, our crown will finish up here, remote from the interface of the roughened surface and the alveolar crest. This here will be all polished collar. Take a look also at this magnified view of a BLX implant. We have a platform switch right here. It's on an angle of about 21 degrees, and if you take one of the many different prosthetic adapters that will be placed on it, you can see again that depending upon the gingival height from the crest of the bone, there will be again a finish line remote from the roughened surface. This will prevent loss of bone at the alveolar crest. The last thing I want to point out in summary is the location of the platform switch for the BLX implant. This photograph, taken in cross-section of a BLX implant, shows that the platform switch is about a millimeter above the alveolar crest. In reality, the treatment recommendations are that the platform switch should be anywhere from about 0.5 millimeters to 1 millimeter below the alveolar crest. There may be some remodeling in this area, but this is the general recommendation. So the last point for me is that the BLX implant has replaced all of the other Strauman implants that I use in my armamentarium. The tissue level implant has been successfully replaced by the BLX. The BLX will go into a extraction socket. It'll go into a site where a locator would go, where a bridge will go, and I recommend that you give it a try.